Welcome everyone to the Wealth of Health podcast. My name is Ahmed, and with me as always is Dr. Paul Jenkins, consultant physician and endocrinologist.
Welcome. Hello.
Today's topic is dementia or cognitive impairment. So, Paul, what is dementia?
Well, dementia is cognitive impairment, significant cognitive impairment. But we're also, in this podcast, I think, is largely going to focus on mild cognitive impairment, which is the important one, which is the stage before full-blown dementia. And that's the one that perhaps we can do the most about to prevent it from developing.
So, as far as I understand it, dementia is an umbrella term.
That's correct. Yeah.
It's an extreme form of cognitive impairment. And under dementia, there are different types, if you would. So can you tell us a little bit about those types?
I mean, overall, dementia it's common. Yeah. I mean, if you take the global amount of dementias, estimated around 1 million people have dementia over the age of 65. And as we are now living longer, every 5 years, the proportion of people with dementia doubles. So it's a major problem. If you're then looking at mild cognitive impairment, it's estimated that perhaps 20% of people over the age of 65 have it. So it's a massive, 6 to 7 million people. It's a big issue. But as to the specific types of dementia, well, Alzheimer's is the most common, and that accounts for probably around 2/3 of the cases. It's a form of, it's dementia caused by accumulation of protein, one called amyloid, within the nerve, in between the nerves of the brain, which interfere with the conduction and the function of the nerves, and another protein called tau within the nerve bodies. So you get that accumulation causing progressive deterioration in cognitive impairment. The second most common type is vascular dementia. So damage to the blood vessels which supply the blood and the oxygen to the brain. A third type is called so-called Lewy body dementia. This is often associated with Parkinson's disease. So patients with Lewy body frequently get Parkinson's and vice versa. And you get it's accumulation of a different type of protein within the brain. And then there's some other couple of sort of minor forms of dementia, frontotemporal lobe dementia, which influences particularly our behavior and personality. And then sort of a type of dementia which affects younger people, quite rare.
So you said it's something about an accumulation of proteins in the brain. Why does this accumulation happen?
To be honest, we don't really know exactly why it happens. There's a number of theories as to perhaps why some people are more prone to getting this accumulation of protein.
So there are different theories about the origin of dementia from what I've been reading, and I know that the group of scientists from Brown's University back in 2005 called it type 3 diabetes because their whole theory was based on the fact that it all has to do with sugar. Is there a direct correlation between diabetes, for example, and dementia?
No.
In a nutshell. So it's just a theory.
Look, that was 2005.
Yes.
We're now almost 2025. I'm a diabetologist, by training. We don't recognize type 3 diabetes. So it's a nice, many things you hear. It's a nice soundbite, but the reality, no. Having said that, though, diabetes is a major risk factor for vascular dementia. So I can certainly, diabetes is associated with significant increase in all types of arterial and vascular disease, and one of those would be dementia. So I can certainly understand that, and also many patients who develop diabetes are also late onset diabetes, are overweight, have high blood pressure, high cholesterol, so other risk factors for developing dementia.
Okay. So are you familiar with a theory called autophagy?
Yes.
Which is basically, it's the process of recycling bad or damaging or damaged cells. And there's another theory that says that dementia is literally a breakdown in that process. So dead cells, bad cells, if you would, are not being recycled out of the body or used for energy properly, and that leads to the to the accumulation of those proteins in the brain.
Yes, I think that's perfectly valid. It could certainly play a role. Autophagy is one of the body's methods of self-cleansing, self-repair, getting rid of all the rubbish, and cleaning itself up. And so there's a hypothesis, and this could certainly make some sense, that the accumulation of amyloid within the brain is due to a failure of autophagy to clear this substance.
Okay, if we go on to talk about symptoms, for example, I personally found this a bit confusing, because there is it's just a normal aging process. I forgot where I put my keys. I don't know why I'm standing in the kitchen. All of that stuff. But there has to be a threshold where if someone passes, they need to be thinking, I actually need to go and get tested, or need to see a doctor or a specialist to make sure I don't have dementia. So how can anyone differentiate between what is a normal aging process and what is past that a little bit?
Well, I think, as with many things, it's a change. If you've noticed a change, or often, probably most commonly, it's the loved ones, the carers or partners have noticed a change. Yes. So I don't think there's a specific threshold per se. But if you've noticed, look, I have a shocking memory. 30 seconds is about my limit. But if you suddenly notice that you're changing, and you're just forgetting things all the time, more than you used to, that would be cause for concern. But I mean, other symptoms, which, of cognitive impairment, are you become a little bit confused, you can't remember conversations so well, or hold a proper conversation, sometimes difficulty in managing tasks,
Right.
forget your cooking, you get lost driving, you get disorientation in time and space, so you can't follow directions, you can't complete tasks, such as handling your financial affairs, or even following TV programs. You can't quite remember the plots of them.
Right.
So I think if those start to change, and you notice there's a definite change in them, then that's when you should perhaps get assessed and checked out.
So we could say that we all forget things, and we all lose a little bit of focus as we age. But if it becomes consistent, or it has an impact on your daily life, that's what probably should trigger
Yeah, I
the
think
need to check.
that's fair. Yes, or if you're concerned and you want to, just exclude it. Because I think what's important
Right.
is there's several things we can do, or several other factors that can lead to a mild cognitive impairment that are, in essence, reversible, treatable.
Right. So they're not dementia.
They're not that they give the same symptoms of cognitive impairment, but they're not dementia per se. So the common ones are, just simple vitamin deficiency. If you're low in vitamin B12, sometimes, to some extent, folic acid, very low levels of vitamin D can cause cognitive impairment. Hormone, as an endocrinologist, hormonal abnormalities, disturbance of the thyroid gland is very common, especially as one gets older, and that's very easily treatable. The metabolic disturbances, which can lead to cognitive impairment.
What's a metabolic disturbance?
Disturbances in the metabolism of the body, in the salts in the body, the salt balance,
Right.
and the fluid load of the body can cause it. A number of medications can frequently cause, cognitive impairment, and especially as we get older, we can deal with clear medications less well, so they can accumulate and cause side effects. So I think there's, these are all factors which you need to have assessed, because if they're there, we can then easily treat them and reverse.
Good. So that's a bit of a positive message. So not every person who tends to forget things or get slightly confused is definitely on the path to dementia. Sometimes it's a lot of other factors that can easily be reversed.
Absolutely, yes.
Okay. So let's talk about the risk of someone, having dementia. Is it all genetics? Or, different question, if it runs in my family, does that mean I will absolutely get it?
No. Genetics is an important, well, there's no doubt, as in your risk of developing many diseases. Yes. And again, you can, probably, like with most diseases, it's probably a third. Yes.
Third what?
A third genetic, yeah. If you so if you do have if your parents have had suffered with dementia, you are at increased risk of it. Yeah? There are some specific subtypes of Alzheimer's where the genetic risk is much higher, but they can be analysed in the laboratory, or you can have genetic testing for it. A third of it is just chance, and a third is probably lifestyle. And we now know that lifestyle can significantly influence your chances or your risk of going from mild cognitive impairment to dementia.
Okay, so can we talk about those lifestyle risks?
Yeah.
Can you? So I mean, the obvious one is smoking.
Smoking is a significant cause for many diseases, but certainly also dementia. Yeah, so there's smoking, there's physical inactivity, very sedentary lifestyle, obesity, there's high blood pressure, high cholesterol, excess alcohol. And one can discuss that and debate that, but some medications, repeated head injury, and potentially head injury in the past. There's a lot of discussion at the moment about contact sports, repeated head injury. Social isolation is an important factor, and then ones that people may not be so aware of, but loss of vision, loss of hearing. They can all increase the risk.
Why is that a risk factor? If
Well, I
someone
think
loses their hearing,
it's a loss of stimulus to the brain.
right?
Is or loss of one stimulus to the brain, and the brain, like many organs in the body, and I believe a more increasingly neurologists believe, needs exercising. So regular stimulation and activity of the brain can prevent or slow any rate of decline.
So you mentioned some medications. Can you? What are some of those medications that can increase?
Any medication that can have a sedative effect.
Like sleeping pills, for
absolutely,
example.
sleeping pills are probably the most common. In general, doctors are now less keen on long-term prescription of sleeping pills. They give what we call a hangover effect. They make you feel a bit muzzy in the morning and confused, and that can accumulate. But there are other medications, a whole range of different medications can have effects on the central nervous system and cognitive.
But sleep is important.
Yeah, absolutely. Sleep. So too little sleep increases the risk. So you want to try and ensure, again, increasingly recognise, but that your sleep is as good and undisturbed and almost as long as possible.
What is the decent average number of hours to sleep?
In general, sort of 7 to 8.
7 to 8.
Yes.
Without.
But everybody is slightly different. But that is probably the ideal for most people. Now, some people can manage on less sleep, but we know that sleep is an important process. And you mentioned earlier about the autophagy and clearance. That's what goes on in part during sleep. This body is resting, slowed down, and it's starting to slowly clear proteins from, especially within the brain.
Okay, so let's say I'm a normal person. Don't comment on that. And I'm coming up to this age where I need to start to look after myself a bit more, do everything I can to make sure I do not get dementia. What should I be doing on daily basis or weekly basis? Or
Yes. Well, there's several steps I think which you can do, which are can be very beneficial. The first clearly is if you are a smoker, quit. As soon as you quit, you start getting some benefits from it and improve your health. So that's number one. Number two is undertake regular exercise.
What's regular?
Yeah, no, I mean, I think that needs to be I would recommend at least 3 times a week of moderate cardiovascular exercise. So that means really getting your heart rate up, to a decent level. And that can be fitted into your, should be fitted into your weekly / daily schedule. None of us, very few people like to do exercise, on the spur of it. There's always something else to do, something better, or a bit of work that needs doing, or something at home or something. So really, in my experience, you need to build it into your schedule. And there are ways you can do it, and there's simple ways. If you're traveling by tube, you get out a stop earlier, and walk that 5-10 minutes. If you're in an office, you get out on the lift 1 or 2 floors before. You climb the stairs. So they're quite simple ways where you can actually get a bit of exercise into your daily routine, which doesn't really impact on it. So I think that's number two would be the exercise, having a decent diet. Yes, so cutting out all ultra-processed foods and trying to have as much, of the Mediterranean diet, which is
Right.
relatively lean meat and fish, vegetables. Nuts and grains can be beneficial. They've been shown to help with the cognitive impairment.
I know there's a lot of debate on the best diet, and we're actually going to talk about this uh, on another podcast when we delve deeper into cholesterol and things like that. But what is a balanced diet, and why are there now so many theories that says, oh, you should not do that, you should just be on a carnivore diet, or you should be on,
Yes.
protein heavy kind of regime?
No, you're right. I mean, it's a topical stroke divisive topic, and people have very strong views.
Mm.
Not always, I'd say, based on science, but perhaps more on attracting viewers and attention. But as with everything in life, probably moderation is best. Yeah? And a sensible diet seems to be reducing the ultra processed. So we don't quite know all of the chemicals in that, but a lot of them, the hydrogenated fats, which give a lot of flavour, but they're just fatbergs. They're just going to clog up your arteries or increase the risk of clogging up and vascular dementia. Just reducing the calories, the refined sugar, trying to reduce calorie intake is a major factor.
Okay. So let's say I did all that, and then I started noticing symptoms still coming on, and the symptoms started to increase. Now, what should I do about it?
Well, if you are concerned that you might have, be developing dementia, then you should have an assessment for it and go to your doctor and have those reversible causes excluded. And they're pretty simple blood tests now. For measuring your vitamins, your routine biochemistry, metabolism of the body, the critical vitamins, and the thyroid function.
And of course, we had a very positive and reassuring conversation with Dr. Aijaz Khan, and he told us a lot about the assessment of dementia and what the gold standard for it is, and also potential treatments that are now available in the UK.
Yeah.
So let's go to our interview with Dr. Aijaz Khan and hear what he has to say. We are delighted to welcome Dr. Aijaz Khan to the Echelon Health podcast. Dr. Khan has qualified and finished his neurology specialist training from Manchester. He is a consultant neurologist at Sheffield Teaching Hospitals NHS Foundation Trust and an honorary senior clinical lecturer at Sheffield University. He also runs specialist clinics in Parkinson's disease, movement disorders, and memory disorders. Dr. Khan, welcome to the Echelon podcast.
Thank you for inviting me.
Fantastic. Today we are discussing dementia, and I wanted to talk to you specifically about the diagnosis of dementia. Personally, I've been researching this a lot, and it was very difficult for me to find a clear, concise answer to the question, is there a gold standard for detecting dementia at an early enough stage so that something can be done about it? And if so, what is it?
Yes, thank you. Yes, it is. It is difficult because there isn't one test that proves or disproves a diagnosis of dementia or a significant memory disorder, and it's a clinical assessment. The current gold standard for diagnosing memory problems would be to have an assessment by a clinician, ideally a neurologist, who will go through the history of the memory issues, then do an examination and a memory assessment. The memory assessments can take a number of different forms. Typically, they run for a number of minutes to give a preliminary score in terms of how one is performing with memory. And then this is usually backed up with tests such as an MRI scan of the brain and blood tests to look for disorders that can affect memory. There are simple things that can affect memory, deficiencies of certain vitamins and metabolic disturbance. So the typical initial assessment will
Sorry,
be,
what's a metabolic disturbance?
Abnormalities of minerals and in the blood, so disorders of the normal constituents of blood. So for instance, if someone has a high calcium or a low thyroid or a low vitamin B12, then it can cause quite significant memory problems, and these can be easily detected in blood tests
And
Okay,
easily treated.
and easily treated. Yes.
so you mentioned an assessment. Can you tell us a little bit more about this assessment? What does it entail? How does it work out?
So the history is the key thing. So going through the details of what's happening. So we'll normally get description from the client themselves as to what sorts of problems they're having, how it's affecting them, and look at various aspects of brain functioning. We look at things that not just in terms of memory, language, ability to negotiate the environment and negotiate spaces, and really assess how the problem is affecting the person. So it includes a detailed history of previous illnesses, medication, family history, and other things that have a bearing on memory problems. So the history part usually takes about 30 minutes. It's more detailed than an assessment for an alternative medical condition.
Mm.
We usually get a bit more time for the assessment as that's required. And that will then be followed by a clinical examination. It's not always necessary to do the neurological examination, but in circumstances that will be helpful. We would then do some memory tests. So I tend to use a test called the Adam-Brooks assessment, which is really very sensitive at picking up memory problems.
Are there different tests generally, or is it just one test that all the
Oh
doctors
yeah,
use?
there are a large number of tests. So there are very simple tests that a primary care physician, general practitioner may do. A quick, 10-stage questionnaire. Again, those are not very sensitive. The tests that we do are, scored out of 100 can take 20 to 30 minutes to do, and really are much more sensitive to picking up significant memory problems. The sensitivity is said to be 97%, which means you will pick up a significant memory problem when there is one to find 97% of the time.
So these
And
are
you,
much more sensitive than the typical ones we used to use in, when I was a junior doctor, the mental test scores, isn't it?
Yes, yeah. So Mini-Mental was used as score out of 30, and really that's quite a blunt tool, doesn't really give you much information. There's another one called a mocker. You may recall President Trump um, uh, stating how he flew through this test with flying colours, and
Mhm.
that was a test out of 30. Again, that's less sensitive than the Adam Brooks. That will pick up a significant problem 86% of the time on average.
Right. So we do the blood tests and we do the neuro assessments. And you mentioned also an MRI. What's the significance of the MRI?
So the MRI is to pick up any abnormality that may be contributing to a memory problem. Sometimes we pick up unexpected things. Um, the MRI will pick up circulatory change in the brain, little dots and spots of in the white matter which show reduced circulation in the brain. When these accumulate, they can also cause memory problems.
So that would indicate to us that it was a sort of a blood vessel
Yes, yeah. So
cause
it can
rather than
it can
Alzheimer's.
yes, it helps in the differential as to the type of memory problem. If there is significant shrinkage in certain parts of the brain, then that does point towards a degenerative process. But it is important to stress that an isolated MRI doesn't give you a diagnosis. You would never diagnose dementia on an isolated MRI, even if it was abnormal.
So you have to do the MRI and the neuro test and the blood test. Can you diagnose it just based on the test without the MRI and the blood test?
It's advisable to do the MRI because it will exclude any conditions that may mimic the memory condition. So you may think that, oh, okay, clinically this looks like Alzheimer's,
Mm.
but the MRI may show something different.
Right. So I've had my blood test now and I've had my MRI and I came to see you and you did the neuro assessment, and I succeeded, for lack of a better word. I did not fail the test. Does that mean I don't have dementia?
Well, it excludes cognitive problems 97% of the time. So
Okay.
it's really, if we still when we assess people, even if people do pass the test, if they're concerns, we can take things further. So, for instance, if many clients we see who are high functioning and perform at high level are actually harder to diagnose in terms of a significant cognitive problem because their baseline level is higher. So they may come down into what would be an average range and thereby, pass the test. But for them, it's abnormal. So we
Hmm.
do have to bear in mind, the level that which the client's functioning.
Okay.
So a pass is not necessarily a pass for everybody.
No, yes, that's right. Yeah.
Okay. Okay.
Uh,
And
and
so there's some, forgive me, is it that there's some sort of new scans which will detect Alzheimer's now?
yes, so there's a scan known as an amyloid PET, and this looks at the abnormal protein that's laid down in Alzheimer's. So in Alzheimer's disease, there's a protein called tau and a protein called amyloid that are deposited, and there is a scan now that can detect that. So if there are uncertainties, we then go on and do the amyloid PET.
And so if there's an uncertainty, or if someone fails the neuro assessment,
Yes,
then they would go on to
yeah.
have the PET.
So,
What's a
so
PET CT? Sorry.
Yeah, so so it's like a CT scan, but an injection's given, and the abnormal protein in the brain lights up, so normally we shouldn't have much amyloid there. We do accumulate a bit as we age. So this protein, if it's in significant quantities, can confirm a clinical suspicion of Alzheimer's disease.
Okay. And I guess at this point, I've gone through the whole process. I went on to have the PET CT. There is amyloid in the brain. Now what happens?
If a diagnosis of Alzheimer's disease is confirmed, which obviously is a situation that one wouldn't want. One would want the test to be negative. But again, if it's confirmed, there are treatments now, new treatments that can actually slow down the disease. So it's quite an exciting time for memory disorders and cognitive disorders. Up until very recently, there was no treatment that had been shown to slow down the rate of progression of the process. So whilst there were tablets which could, maybe help the symptoms a little bit, and we always encourage lifestyle changes which might have some effect on outcomes. There was no actual treatment that would affect the process to slow it down in terms of drug treatment.
Hmm. And
Uh,
sorry, can you tell us a little bit about that treatment? What does it
yeah,
do?
so
What is it
the new
called?
treatment is there's a drug called lecanemab.
Hmm.
So it's actually an antibody that's given as an infusion, and it clears away the abnormal amyloid protein. And studies have shown that it does slow down the rate of progression of the condition. So the data would suggest about 27%, nearly 30% slowing of the progression of the condition. That's over a year, 18 months. Again, long-term data still needs to be clarified. I mean, if we're getting 30% over a year or so, then over a few years, that may well become even more significant.
Okay. And does it actually, when you say slow it down, it means it stops it at its current condition. It doesn't make it get worse. Or do you mean actually reverse the damage that may have already happened?
Well, it tends to stop things getting worse or slow it down. It tends not to improve the memory, but it keeps it at that level. So if you look at the studies, a certain proportion of people over a period of a year showed no worsening at all. Um, and that the percentage of people who showed no worsening was much higher in the group having the treatment, the lecanemab, compared to people who weren't on treatment.
And is this medicine now here in the UK? Is it available?
It will shortly be available. So it is. There's a body called the MHRA, which is a body that approves medicines, like licenses medicines for use. and MHRA has approved this. It is fully approved in the States, so lecanemab is available in the USA and is covered by Medicare and Medicaid and insurance companies there. So it's fairly, it's fairly fully approved in America. Here we have a body called NICE. There was a ruling recently in the news. NICE look at the benefits, they look at the risks, and they look at the cost. And they decided that it wasn't appropriate for the NHS to pay for it, which has disappointed a lot of people. But NICE have not approved it yet. That may well change as data accumulates and more evidence for it is collected. Then they may reverse that decision.
But Aijaz, I mean, two things. So NICE is firstly for the regarding the public
NHS,
sector, isn't it? NHS.
Yeah.
So it's dividing up the cake, how best to divide up the NHS cake between all treatments. But secondly, what is the approximate cost of lecanemab?
Well, at the moment we've got the US cost, which is $26,000 a year. So it's going to be equivalent. So it is an expensive.
20,000 sterling a year.
Yeah.
Okay.
Sorry, and
do you think it will be given? I know the studies have been 18 months, and clearly there'll be longer ones to come. But do you think it's going to be an ongoing sort of, you have this drug every 2 weeks indefinitely?
Yes. So the MHRA, the body that approves the drug, has licensed it for indefinite use. So the way it works, there is, we believe it would continue having a benefit. So you can keep going with it.
So 20,000 a year indefinitely. Okay. But it's not without, like all medicines, but it's not without risk, is it? There's been some significant side effects.
Yeah, there have been side effects there. So the most concerning side effect is that it can cause little areas of swelling in the brain and little areas of bleeding. Whilst that's not uncommon, there were 2 or 3 kind of serious incidents out of maybe 1,500 people. Yeah. So the risks are low, but there is a small risk of a significant side effect.
Okay, but did it cause any fatalities?
Yes, it did. It caused 2 fatalities.
That were attributed to the drug?
Yes, yeah.
Okay, so it's something has always to bear up the sort of the risk benefit.
Yeah.
So these are very, yes, it's been licensed. It is an early stage treatment. Do you think as time moves on, the treatment will be more available? Other companies will develop similar drugs, hopefully with less side effects, and it will become cheaper as well.
Yes, so I think it's exciting because I think we're at the beginning of the end for Alzheimer's disease because there are a number of drugs coming. So in the States, another drug called donanemab was approved, and that's been fully approved, and that slows the rate of progression of Alzheimer's by up to 40%. There are quite a few drugs in the pipeline. There are tablets, there are injections. So I think it's only a matter of time before we will be treating Alzheimer's disease as we treat cancer with combinations of medication. Dementia is the biggest killer in the UK, above cancer, above heart disease. And if we think of the treatments for heart disease and cancer, and then compare that to the treatments for Alzheimer's until now, we're looking at a radical shift in how dementia will be treated.
Well, it's a very optimistic, almost ending to the podcast to say this is the beginning of the end of Alzheimer's disease.
Yes, I believe so.
Wow.
Absolutely.
Yes.
And so, Dr. Khan, well, I guess just extracting a little bit from what you said, the treatment stops the progression of the disease. And Dr. Jenkins and I were talking earlier about kind of signs of when you should go and get tested. Well, I guess the message is people should go and have the assessment as early as they possibly can. If they start to notice symptoms, if their family or closed one starts to alert them that there's a change, significant change enough to be noticed in their memory, then they should just go and get checked.
Yes, that's what we would advise. In fact, nearly 1 in 3 people who actually have dementia don't have a diagnosis, and haven't been given a diagnosis. So it is under-recognized, and the key thing now is to diagnose it early so it can be slowed down at an early stage.
Okay.
So I just wanted to reiterate that, Aijaz, because is it not the case that, like many diseases, the earlier you detect it, the more effective the treatment can be to prevent it from worsening, like
Yes,
heart
that's right.
disease, like
Yeah,
cancer.
yeah, yeah.
And I guess also, the program or the sensitive sequential screening assessment that you have eloquently outlined, um, is that generally available on the NHS, or is it more in the private sector? And am I correct that you've recently in London established a centre specifically for this screening pathway?
That's right. We've established the Marylebone Memory Clinic. So in terms of what's available in the NHS, one would have a history examination, bloods and an MRI scan. So at a memory clinic, that would be fairly standard. What we do have access to are PET scans, which even though the NHS only scans about 2% of people who go through a memory clinic with a PET scan, even though it is it's a recommended, and even the NHS themselves recommend access to PET scanning, but it's
Fantastic.
very infrequently done. The other test that we use in memory clinics is a full neuropsychological assessment. Sometimes a neuropsychologist spending a long time and going through memory testing in detail. It's quite a rigorous assessment in terms of it takes a number of hours and sometimes done on more than one day. But that can also add further information where there are difficulties in confirming a diagnosis. So we have access to neuropsychologists, which are required in the minority of people. Not everybody requires a neuropsychological assessment. We also have access to PET scans. Should there be any doubts about the diagnosis. The other key thing to say is that to be eligible for the treatment, the lecanemab, the anti-amyloid drug, you have to show that there's amyloid in the brain. So that's done either with a PET scan or with cerebrospinal fluid analysis, which involves taking fluid from the spine, which is, again, an invasive procedure. So prior to any treatment, one of those two tests will have to occur.
Okay.
Now, there's also, can I just, is it not very exciting that there are potentially blood tests for Alzheimer's being developed for
Yes,
the tau protein? And I know they're
yes.
not currently available, but
Yeah, they're not currently available. In the future, blood tests will become more important. They won't answer the question all the time, and they're currently being assessed in terms of when is appropriate to use them and at what time and what the significance is. But yes, in the future, blood tests will almost certainly be more commonly used.
So, Dr. Khan, thank you very much. And I asked Dr. Jenkins this question earlier in the podcast, but I will ask it to you as well, just to see if you're both going to give the same answer.
give the same answer.
Your top 3 tips to protect oneself from potentially getting dementia.
Yeah. So the top 3 tips would be to healthy diet. So we know that certain diets prevent dementia. So it's sometimes referred to as a mind diet. So it's similar to the Mediterranean diet, low in. I think most people know what's healthy and what isn't healthy. So low in fats and high in fruit, nuts, berries, fiber. So a good diet is important. Maintaining an adequate and an appropriate body weight is important as well. And exercising, keeping fit is important. We do know there are lots of factors that can affect the onset and progression of dementia. So we normally recommend a number of things, but the key things are maintaining body weight, good diet, exercise, and what we refer to as vascular risk factors. So it's things like blood pressure, cholesterol, making sure diabetes or pre-diabetes is controlled is another very important another set of factors that can influence the onset of dementia.
I
That's
think I said
exactly what
earlier,
Dr. Jenkins said.
summarize it, what's good for the heart is good for the brain.
Yes, yeah.
So, well, you passed,
Fantastic.
Aijaz, because those are all the things that I'd said. So thank you so much.
Thank you.
Dr. Khan, thank you so much. That was very informative and also very positive. Thank you.
Thank you, Aijaz.
Thank you. Thank you.
Okay, well, that was very interesting conversation with Dr. Khan. I think a lot to be positive about. Regarding the gold standard for assessment, which is the blood test, the MRI, and the neurocognitive test, but also the potential treatment.
This is fantastically exciting. You know, dementia throughout my medical career, you know, dementia until very recently, there wasn't much we could do about it. If anything, you could, you know, diagnose it, but then that was sort of about it. So this new drug is, you know, as Aijaz says, potentially the beginning of the end of dementia.
Yes.
And I think, you know, we should remember that yes, it's not available currently in the on the NHS, but you know, times will change. This is the first of many, many drugs that, you know, numerous drug companies are trying to develop, because, you know, the treatment of dementia is one of the almost the holy grails of medicine. So I think there will be many more drugs coming down the line. The price of them will, you know, undoubtedly fall, and hopefully will then become available on the NHS in the not too distant future.
Well, I think we should end on this positive note. Thank you, Paul, and we'll see you on the next one.
Goodbye.